A very good afternoon and good evening, everyone. I'm Dr. M. Surya Jaswal, currently pursuing PhD in oral and maxillofacial surgery from Busan National University, South Korea, and I'm the host for today's session. Today, we have once again Dr. Mayur Khairnar from India with us. He has done, if you don't know, so let me tell that he has done masters in periodontology and implantology, and he's an expert in oral implantology. He is also a fellow and diplomat of ICOI and currently pursuing PhD in dental implants. With over 26,000 successful dental implants placements, he specializes in graftless immediate loading solutions. So, this webinar will discuss the clinical advantages, biomechanics, and surgical protocols for two-piece bicortical implants, emphasizing their application in full arch implant restorations and rehabilitation of periodontally compromised dentition.
Thank you so much, Shreya, for the lovely introduction. I would like to share my presentation now. Just a moment.
Yeah.
Okay. Is my screen visible?
Yes, it's visible. Just do it in slideshow mode.
Okay, it's fine now? Yeah.
Perfect.
Okay. So very good afternoon, everyone. We being an Indian nation, we have been going through a tough phase, but still we really appreciate your energy. Even in this particular situations, you are going in a positive framework and trying to learn something new. That's great for all of you. And we being a good nation and a great nation, we will have some positive outcomes in the future. Coming to the topic. I would like to know how many of you must be having a lot of cases where periodontally all the teeth are compromised, and I mean there the dentition is hopeless, and they are coming to you for restoration, and they don't want to wait for long period of time because nobody wants to stay edentulous for long period of time. They want immediate replacement. How many of you must be facing certainly such issues? I'm sure majority of you. And how many of you think if you can see the images of patients before and after transformation, how many of you think if you are in a situation to do such kind of transformation for periodontally compromised dentitions with or without severe periapical infections, bone loss, so many things, their transformation without any bone grafting, without any, taking major time, like immediate loading. How many of you think if you employ such kind of a practice in your clinical day-to-day clinical practice, how many of you think this would be a very good investment to your practice? And such patients, if you can also make a positive change in their life with respect to everyone wants to eat well, right? As I've said, what matters is to improve the quality of life, and with this particular things of having a right function, right chewing capacity, such patients will be a good referral partners for you or your clinical practice in future. So, my friend, today in this topic, I'll be speaking about how periodontally compromised dentitions, very severely infected periodontally compromised dentitions, we can do full mouth implant reconstructions with or without bone grafting, or sometime majorly without bone grafting with the help of a cortical TPR implants, but sometime with immediate loading and sometime without immediate loading. Both the options are open. So it's all things. So I'll be showing you certain cases, the techniques, and what is the principle of cortical TPR implants, specifically to this particular type of cases. Okay. So when it comes to dental implants, okay, this is a common picture which comes in our mind. It's like, one single missing teeth is there, and then now you have to replace that teeth with one single implants. Now, here the patient have an upper choice. They can go for either implant supported, instead of implant supported bridge, they can go for a dental teeth supported bridge, or they may not restore anything also, because one teeth sometimes some patient doesn't make any much difference in chewing capacity, right? But we keep convincing patient for such kind of indications, like let's do implant for your single molars, let's do implant for single teeth. If it is a single front teeth, patient will be having a high emergency and they will always opt for implants or some kind of dental bridge. Okay, but is this the only indications for dental implants? Not really. Okay, if you go to such scenarios where posterior teeth are missing bilaterally, upper and lower, or majority of teeth are loose or compromised periodontally, there uh, patient have no options other than dental implants, or already the teeth is been extracted. Their patient have no options other than receiving dental implants to receive a fixed teeth. Okay, but what is the problem with such kind of cases is such cases are always complicated with the deficiency of the bone. Okay, and of course the deficiency of time, because uh, here what happened, because the bone is deficiently, you are relying more on a bone grafting or some kind of removable option. Patient will try to search for certainly some options where this can be done in a minimal less period of time, or with that without major bone grafting procedures, because some patients are smoker, they don't want to quit smoking. So many factors are there. Diabetes is there. So not always the bone grafting is successful, right? So patient will try to go for less invasive options in that case. However, if you just shift your focus and upgrade your teaching or your skills, you will be in a situation to solve such cases even in a minimum possible time, right? And you can really deliver the goal, a treatment goal which patient is desiring. Okay, within the limits, it is increasing the quality of life or improving the quality of life of the patient. Okay, I repeat again, the most important thing is improving the quality of life of the patient, right? So even in such cases where the bone is very thin, even in such cases, especially full arch cases with such thin bone, it is today possible to give patients fixed teeth without any massive bone grafting, without giving any removable options, and without rejecting the patients, right? So definitely today that is possible, and everybody knows. No, if the orthopedician can make their patient walk in 3 to 5 days after hip joint replacement or knee joint replacement, then why can't we make our patient chew in just 3 to 5 days, right? And today we are doing it. Like majority of the cases where the bone is having a decent quality of bone, we are in a situation to load the implants immediately and give patients the function. Okay, so what is the concept of orthopedicians? They are placing in order to join the two fragment, a fracture fragment, they are placing implants which are bicortical. Okay, they are non-parallel to each other, and these particularly the screws, okay, are splintered to each other with the help of a rigid fixation plate. Okay, they are engaged into the bicortical bone, that means highly mineralized bone. Okay, and they are being told, a patient has been told to do the function with the help of a physiotherapy of a gradual function, within certainly 3 to 4 period of days of time patient. So it is kind of an immediate loading. So what today orthopedician was been doing since a century, we have been doing this thing since last 20 years. Okay, we are also placing nowadays a lot of non-parallel implants, also called as tilted implants. Many of the time the implants are engaged into the bicortical fixation. Okay, but all depends on the anatomy of the or topography of the implants. Some implants are wide enough where bicortical fixation is not very easy, whereas certainly some implants like cortical TPR are very easy to engage the bicortical fixation. Okay, the third thing is that now all the implants today nowadays are rigidly splinted with the help of the metal framework, and we are trying to load it as soon as possible within 3 to 5 days. Okay, so the concept is derived from the orthopedician concept or traumatology. Okay, this concept is nothing but an immediate loading concept where all the implants are engaged into the basal cortical bone. So we call it ABC. Okay, so this is a X-ray. If you see this, this is an X-ray of Brandemark's study, or where he was, he was basically where on this particular X-ray he coined the term osseointegration. Okay, he was studying the tip RBC flow with this particular titanium optic chamber. And when there was a time to retrieve it, he was not able to retrieve it. Why? Because he found that this titanium optic chamber, along with the fixation screw, got integrated to the bone. Now, he coined it as an osseointegration, and he did beautiful research, no doubt about it. He made a beautiful invention, but most important thing which he missed out was this bicortical fixation. This particular screw was bicortically fixated, and that was never mentioned by anywhere by Brandemark, right? And that's where the concept of delayed loading came into existence. Okay, so there has been a commonly used a lot of bicortical implants which are single piece in the Indian market or many other places all around the world. This works good when it comes to surgical, but when it comes to prosthetics, there is a lot of hassles because these are all cement written, and when it's a matter to remove this process is a big headache. Okay, so yes, even I have used certainly certain cases, but the retrievability is a major problem with such kind of bicortical single piece implants. Okay, so I'll give you some example. This is a case which is done long back in 2016 or maybe before that. So here, lower left segment got problem after certainly 5 years. So we had a very tough time to remove these bridges. After removing the bridges, we later on did, this time we didn't go ahead with any kind of single piece, but we went ahead with simple, straightforward 2-piece implant that are retrievable, and then we joined this implants to that. Okay, so the anterior 4 implants are the 2-piece implants, which was initially placed by some other dentist, and overdenture was there. So we just changed it, and we use all these anterior 4 implants and posteriorly 2-piece implants. Okay, so that's the advantage of retrievable processes. So we just avoided that thing over a single piece implants. Now, if you see this is a screw retained 2-piece implants, which is called cortical TPR, which is similar to the bicortical implants single piece. The only thing is that in this, the multi-unit abutments are fixed, and you can overcome the non-parallelity of the implants, and you can have a beautiful prosthetic outcome.
QuickDent
Okay,
implant
so I'll just show you
innovations,
this.
crafting smiles with confidence.
Is this audible?
Introducing the QuickDent Corticale TPR implant, the perfect solution for full arch immediate loading, utilizing second cortical plate anchorage. Designed to engage the second cortical plate from the pterygoid plate, anterior nasal spine, it provides unmatched stability.
So the
It is
non-parallel
also
implants,
ideal for immediate placements post-extraction and for
it can be
bypassing
also
the
used
mandibular
for no
nerve,
bypass.
ensuring safe and predictable results. All of this is possible due to its unique and advanced design. At the top, a polished collar with micro grooves enhances soft tissue adaptation and reduces plaque accumulation. In the coronal
the
third,
crestal,
compressive square-shaped threads compact.
so the crestal, sorry.
QuickDent implant in a QuickDent implant innovations.
So if you see the crestal area of the implant, that is polished, and this is a fantastic feature of this particular implant, because in periodontally compromised dentition, the bone is never uh, at the same level on the buccal and lingual side. Many a time the buccal bone is lost and lingual bone is at quite higher position. Okay, so many a times, implant when placed in periodontally compromised dentition sites, there is a need where the buccal bone is exposed, or a buccal side of the implant is exposed in the crestal area, and you need to do a lot of bone grafting and cover it with the membrane. However, if TPR, certainly the crestal bone is a little bit exposed, it doesn't make any difference, because it can be used, this particular part, polished part, can be used as a 1-stage implant also, and also as a 2-stage implants also. So that's absolutely safe to go ahead with.
In the middle third, reverse buttress threads facilitate smoother insertion and direct occlusal forces deeper into the bone for enhanced stability. The apical third features sharp V-shaped threads designed for bone cutting and achieving superior primary stability.
So if you see this, in the apical area, there are aggressive threads because of which, even if your bone, you're drilling, these implants are very active. You don't have to do much drilling. That's the best part. That cuts the dense cancellous, dense cortical bone, and the squarish thread which you see in the crestal, below the crestal part, that is a compressive thread that compresses your cancellous bone also.
Two strategically placed compaction grooves at the sides aid in autografting, further promoting osseointegration. The polished tip ensures optimal engagement with the second cortical plate, providing maximum anchorage. Made from grade 5 titanium with an RBM surface treatment, and featuring a 2.42 mm internal hex connection for prosthetic compatibility.
So if you see this, the tip of the implant is having a polished area, and it is very narrow also. So with the minimum drilling, it will just catch the bone. I will be showing you the video about it, and it will keep expanding the bone. So it works as a bone expansion screws also. If you see, there is a groove inside this particular implant. This groove is nothing but it cuts the bone and it condense the cancellous bone around the implants also at the same time. So that's a beautiful feature. We call it sharpener effect. If suppose there is a buccal bone defect, so what happened because of this particular groove, the bones comes out and try to fill up on the buccal aspect of the defect. So that's another beautiful feature of this particular implants. Okay, this is RBM treated typical tip 4.2 internal X
TPR implant.
Majority of the implants. Okay, so this is nothing but a bicortical fixation. Immediate loading can be done with two approaches. One is bicortical fixation, one is bicorticalization of the cancellous bone. That means doing under osteotomy and placing a wider implant, condensing the cancellous bone. Okay, so when the bone is very thin, normally, if we place the standard conventional implants, okay, there is a chance that the bone can get, the implants can get exposed in the crestal area, and definitely will need some kind of bone grafting. Whereas in cortical TPR, even in the most thinnest bone like 3 millimeters or 3.5 millimeters, it is possible to place 3.5 millimeters without any exposure. So here, you just, it just expands. So I'll just show you certainly a video. So this is around 3 to 3.5 millimeters width of the bone, and the drilling has been done and the implants is being placed. And if you see, because the buccal bone is having little defect, because of the sharpener effect, the bone is coming out and it is getting accumulated at the buccal aspect. If you can appreciate that, that's the beauty of this particular design. Plus, now you have two options. If you get a good torque after engaging the second cortical bone, please go ahead with the straightly immediate loading. If you don't have a good torque, because suppose by chance the cortical bone, the second cortical bone or the basal bone is also very thin, that time just stop, place the cover screw and do the delayed loading. So it is up to your judgment whether to do immediate loading or delayed loading. It all depends on the torque. If you get a torque of more than 45 to 50 degree or 50 Newton centimeters, then definitely you can do the immediate loading, right? So these are the target bones in maxilla and mandible whenever we are doing full mouth rehab. One is the nasal floor, zygomatic, pterygoid implants. In the posterior, we have either the buccal cortical or lingual cortical. Or in the anterior mandible, we don't have any specific target set because whole bone in the anterior mandible is a dense bone. Except situations where the bone is very, very hollow in anterior mandible, we can engage into the base of the mandible, okay, anteriorly. So that's the exceptional situations, okay. Plus, the best part of this particular implant is that, it has multi-unit systems which varies from 0 degree till 60 degree depending upon the angulation. So you can overcome all the tilted angulations and you can make the prosthetic platform absolutely parallel to each other, right? Even if the implants are non-parallel, your prosthetics is very parallel to each other. Okay, that is possibility, particularly with the help of multi-unit systems, you can do that. See, implants are also very thin enough, especially, so you can sometimes bypass also. So you can see in this case, the third molar, maxillary third molar is being bypassed on the palatal side, with the implants, right? And this is multi-unit. This is also a multi implant with the multi-unit. This is the open tray impression. You can see, or you can, I would say this is a jig trial where one screw test is being done, because that is the most important, successful element of any prosthetic face. If your jig trial is and your one screw test is not perfect, what will happen? There is a chances yours will have a screw loosening, you will have an active process, then implant may eventually give up. Okay. Today, with the help of a digital protocol, it is easy to restore the cases with the digital way. All the QuickDent has all the scan bodies, all the digital analog, all the digital protocol, prosthetic protocols are there. They're also coming up with the guided approach, a refined guided approach, and the softwares. So the processes which we get is a screw retain processes, and it can be easily retrieved. For example, in this case, okay, we extracted, we gave a screw retain process to the patient, and after 1 year, when patient came with the broken prosthesis, okay, if this would have been a cement retained prosthesis, it would have been a big headache to take it out. We just took it out in 5 minutes, and this is a beautiful healing around the gums in the maxilla. And we sent it to the lab. Lab corrected it 1 day, and next day we gave it to the patients. Okay, so I'll also at the same time explain you about a recent PubMed index journal publication which we did, where we checked the impact of full mouth reconstruction with respect to oral health related quality of life in patients with atrophied jawbone. And this case, these were all cases included between 2017 to 2024 were included in these studies. Okay, so what we evaluated was whether the patient emotional aspects was improved or not, oral hygiene were improved or not, whether the emotional aspects like patient's job or environment, whether there was any changes in that, uh, function was improved or not, chewing, speaking, smile, everything, and whether the patient was satisfied over a period of time or not, how many referral did he give later on, all these things was evaluated in the studies. And we found that there was a tremendous improvement pre and post treatment with respect to all these parameters. So I will be showing all the cases of periodontally compromised dentition with respect to oral health related quality of life index. Okay, so if let's take this scenario, this female, she's having absolutely less bone, at same time periodontally compromised dentition. If you see less bone in the sense, in the anterior, the bone is very thin in maxilla. So I'll show you the CBCT scans also, but the tooth is absolutely, the whole jaw, upper and lower teeth are hopeless. So if you see this in anterior, absolutely thin bone is there. There is no particularly width of the bone. So definitely it will need some kind of bone grafting, that too after extraction of the cases. And then patient have to wait just for long period of time, like 6 months, to this bone graft to get matured, and plus healing after extractions and all these things. So it will definitely take a long period of around 4 to 9 months to get this case ready for the implant placement. Okay, well, how we did this, we just extracted, we avoided the area where the anteriorly, especially we avoided the area where bone was very thin, and we placed the implant which was 3.5 diameters, little longer, because the distance between first cortical and second cortical was great enough. So we placed the longer implants engaging the bicortical fixation. We avoided anterior area. Same way in the lower jaw, we did the same thing. If you see in the lower right side, we engaged the base of the mandible because bone was not sufficient enough to give us a good torque. So we just changed that implant to some other side, and we chose the longer implant, and we placed the bicortical fixation in the lower jaw. Every implant is gone with a fantastic torque. Now here, this prosthesis was given to the patient. This is a standard acrylic hybrid prosthesis, kind of a transitional prosthesis, which is given to the patient on day 3. This is just a post-treatment radiograph after giving the prosthesis. This is before and after treatment. That's her day 1 versus day 3, and she was comparatively comfortable compared to before. Her parameters of oral hygiene related indices were improved, right? But when she came after 1 year, because this is an acrylic hybrid processes, there is a chance, and this is a transitional, there is a chance that sometime it can fracture. So this teeth was fractured, the canine one, and there was a lot of course, because of the shrinkage of the periodontally this compromised dentition, the gums shrinked, right? There was a shrinkage between the existing processes and the area, soft tissue area. Okay, so we retrieved the prosthesis, we checked for the healing of the soft tissue. The healing was fantastic compared to, you can see the before day one and the healing of the gums around now. It is quite good enough and all well. And we rebased the prosthesis, we recorrected the maxillary teeth. In fact, her teeth were changed and we gave the process because she didn't want to afford, she cannot afford to go with the permanent prosthesis. So we again gave her a hybrid acrylic prosthesis, but it was more refined with the Nato-Star teeth sets. So these are the good teeth set which have a high abrasion resistance. So these teeth set were used, and then this is a follow-up of the patient now still 5 years. Okay, and another case. So this is a female who came to us long back, I think 2018, and this is her in recently 2020, 24, something like this. Okay, so this is patients before and after periodontally compromised dentition. Of course, teeth were mobile, so we decided to extract all these things. But here in lower anterior, the bone was very thin. On contrary to previous teeth, previous case upper anterior teeth was thinner. Here lower anterior were absolutely thinner. You can see this here. The bone is absolutely very thin in the center of the mandible. Okay, so we decided to plan the case accordingly, and this was our plan to avoid placement of implants into the lower anteriors whenever possible. It's not that we cannot place it, but if we have a bone in other regions where we can still get a good torque and good bone is available, definitely our more, when it is a full mouth case, you have an option to shift your osteotomy site from one area to another end. If it is a single tooth case, then you have no options. You have to place implant right there itself, right? So we decided to avoid placement in the anterior. Okay, and we place implants like this. This is implant has been placed. We did, in this case, we decided to trim all the flaky bones, which may resolve in future. Okay, before extraction, if you see, the gums were not very much inflamed as it was before first case. First case, it was very much inflamed, so their expected soft tissue recession was there. Here, the gums were not too inflamed, so expected recession was minimum. So we decided to go ahead with the metal framework, that is a PFM processes. This trial was done. We got a screw retain process to the patient. We placed this, and this is the day 5 X-ray of the patient. If you see, we reduced the bone everywhere needed. Okay, this is the patient before and after. This is after the 5 years of treatment. Okay, can you see the significant amount of shrinkage? There is not at all significant amount of shrinkage, okay, as compared to the previous case. Why? Because we planned the process in such a way. We reduce all the flaky bone. We also thought what kind of thickness of the soft tissue patient is having, because that matters a lot. If you have a thin biotype, the chances of bone loss or a recession is high. With a thick biotype, this is very minimum. So depending upon all these factors, we decided to choose whether to go for a transitional or permanent. We decided to went ahead with the permanent process in this case. Okay. This is the post-treatment radiograph of 3 years and 5 years. All the bone levels are stable. Now, if you see, everyone sometimes claims that soft tissue, soft collar is there, smooth collar is there for the implant. It may cause some kind of bone loss. So, if my friends, if you follow two simple things, the bone loss will be minimum. Okay, one is always let your bone implant get surrounded by the bone circumferentially. At least 2 mm bone should be there all around your implants. Okay, this is point number one. Point number two, what you should be taking care is you should not exert too much of crestal, I would say, force or a crestal torque on the around the crestal bone. So your torque from the apical region should be good enough, but not in the crestal region. If you exert too much of pressure or compression on the crestal bone, there is chances you may lose the crestal bone. The another thing is that if you are not using a passive prosthesis, the bone loss may happen. Okay, so the third and the most important thing is make your process as passive as possible so that crestal bone loss can be easily minimized. So it is a myth that always the crestal polished implants will have a bone loss. It is a myth. Sometimes it may happen because of these three factors, not because of the implant is polished. Okay. So that's a smile follow-up of the patient, absolutely. And now
मला वाटतं मला जादूच केली ह्याच्यावर असं म्हणजे एवढं मला खायला मिळतं मी हसू पण शकते अगोदर मला हसायचं म्हणजे तोंड बंद करून हसायला लागायचं आता मी मुक्तपणे हसते आणि एवढं मला बरं वाटतंय ना मी याच्यात पैसे इन्व्हेस्ट केले पण मला असं वाटतं की मला करोडचा फायदा.
Okay, so what she is saying is she feels like the magic is happening in her life. Okay, and she has invested this money that is like crores of she have got returns in crores, not in terms of money but in terms of improved quality of life. I hope you understand this. So this is the patient speaking after 5 years. Okay, so let me show you another case. This female maxillary teeth are totally missing, but lower teeth are all supra-erupted. See, her smile is compromised. This lower teeth is eating up the maxillary bone, actually, to be honestly. It is creating indentations in the maxilla also. A lot of things are there. So here, still the bone was not too much thick, I would say, but yeah, it was not bad as well. So we decided to go ahead with the flapless. So if you're not confident enough, please don't go flapless. Otherwise, you may land up in placement where one of the wall of the bone is exposed to the soft tissue of the implants. So it is not advisable options if you're not confident enough. So here the bone was good enough. We went ahead with the soft tissue. We went flapless here, and we avoided zygoma by placing additional implant. And this is the trial of the patient. Metal trial of the patient. See, in every case, we do something called zig trial. Okay, and in this zig trial, we check whether the one screw is attached. If you see in maxilla, there is one screw is attached to the impression post. In mandible also, one anterior screw is attached to the post. So this is very much important. And then we do the metal trial. Process has to be absolutely passive. This is the patient's before and after. This is the patient after smiling. And there has been a tremendous change in her quality of life. So this is after 3 years of follow-up, almost 3 years of follow-up. This is after her 3 years of follow-up. Okay, so there is a little amount of shrinkage, little ceramic she might have chipped off, but that is okay. That is a part and parcel of the maintenance. If required, we can do that. But if you see, the shrinkage is very minimum comparatively, very minimum shrinkage. That's why, because the soft tissue thickness was good enough, although it was inflamed, but we reduced we opened the flap, we reduced completely flaky bone. We got a stable landmark for placement of implants so that the bone will not resorb much. And we reduce all the flaky soft tissues. These soft tissues which were very spongious was all resected with the help of the scissors. And we did a kind of a perio surgeries for the lower jaw, okay, without teeth. But so all granulation tissues, everything was resected and fresh tissues was used and closed. We had a minimum shrinkage. Another case where, if you can see the lower teeth, all teeth are flunging around because of severe infection. Upper teeth also, almost all teeth are compromised. But here, the patient medically was not very sound. Okay. In fact, after the placement, we had a episode of she going in a syncope. So we decided to go with the delayed loading for her because it's not, it's okay if patient medical is not, she's not medically or he is not medically supporting you for the treatment. Okay, so we did this placement, and after 2 months, when patient came, we attached the multi-unit abutments and rest of the thing. And this is after 2 months. We gave 2.5 months probably. We gave her the transitional prosthesis. Okay, this is the patients after, and smile or sorry. Smile. Okay, so she is being happy and smiling now, and it's now she recently gave us the 2-year follow-up also. Everything is stable and good enough. Okay, so areas where infection was there, we placed the implant at deeper level, especially you can see lower anteriors, especially in the fourth quadrant and like around 4-3 region. The implant is being placed much deeper, and we use a higher height multi-unit abutment. On contrary, the same on the 3-3 region also. Okay, we use a higher collar multi-unit abutment because implants were placed deeper because of the infection of the bone or because of the structure of the bone, like that. Okay. Another case, in this case also similarly, the prosthesis was loose and she has undergone some pin implants locally somewhere, and she was having all these problems. She was not able to chew properly. So we decided to remove her teeth, okay, clean it up, and we place the implants. Now here we placed implants and we submerged it because these two anterior implants are the most weakest, were the most weakest implant among all 6 implants, and we didn't want it to give immediate loading to her right that moment and compromise this 2 implant which is being placed. Okay, because she is a medically compromised patient. She is having a severe hypertension, and there if we do that, there's a possibility that this patient may will not be able to enjoy the fixed teeth. So we decided to go delayed loading in this case again. Okay, and once the patient came here, we went ahead with the, this is the follow-up of the patient. So it is by mistakenly mentioned as a day 5, but this is after 2 months actually. Okay, and this is the patient's before and after. This is after 2 months, after proper healing of the soft tissue, everything is there. We gave a hybrid process to the patient. This is a mild hybrid. This is quite light in weight and she is absolutely easy. She is able to chew well and she is able to eat well. Okay. She is before and after. Okay, so that's a correct thing. So it's after 2 months, after 2 years, and after 4 years. So it's not day 5. We did a delayed loading for this particular case. Lower is still stable, so we didn't do anything to lower till now. Okay, but definitely that's not the way to do the treatment. Pin implants are not advisable on such a because it is not ideal way to do the treatment. Patient, we cannot retrieve the teeth with the pin implants. Okay, so anyways, it was stable, so we didn't do anything to it. There's another case of periodontally compromised dentition. See, because of this flunging bridge, if you can see the defect in the canine region. Can you see this here defect here? The defect is so massive. Okay, so we are left out with no, we don't have any bone in the canine and lateral region because of this particular defect. So there is only bone in the anterior region that is available is in the 1-1 and 2-1 region. That is in both the central incisors. That's it. 2 sites in pterygoids and 2 sites in zygoma. Okay. So that's where we placed 2 implants in the central incisors region, 2 in the zygoma, 2 in the pterygoids. Lower was a standard bone, so we placed the standard way we place the implants. Posterior implants, if you see in the lower, they are engaged into the lingual cortical bone. Okay, So with the CBCT, you can judge that, engage into that. This is a follow-up of the patient more than 2 years. Now, this is I think this is done in 2021. This is now more than 4 years old, but we have not yet received the follow-up of patient more than that. Okay, so this is another case. Now, this is before and after of the patient. You can see that this is a hybrid process which is given to the patient. That's her smile before and after. See, she is with her husband. We did it during the Corona time, and he is also very happy. There's been tremendous change in her confidence level. Now, when she comes and she talk, her confidence levels are massive, different, very different level she talks. Okay, and when she came for the first time, it was like she was subjugated. You know, she was very low right that moment. So this is a follow-up. Okay, we have a 3-year follow-up as well of this particular case. Okay, so this is another case of this. Now, this is a periodontally compromised dentition along with the resorb jawbone. Okay, so if you see this, one moment. Okay, so here this is the CBCT section. Even the maxilla and as well as mandible was compromised. Mandible anterior bone was okay, but posteriorly height was compromised. Maxilla overall it was compromised in the height. Okay. So because we are placing the implant tilt only, I think 6, 7 millimeter, 8 millimeter implants were height was there. So implants were placed. We were placing the implant with the tilt approach. So we could place at least 10 millimeter implant in the premaxilla. We place zygomatic implants and we place the posteriorly most posterior support with the pterygoid implants. These all implants are placed with a one single drill majorly. Okay, and posteriorly we did a nerve bypass because the bone is thinner enough. It is very easy to do the nerve bypass with the thinner 3.5 diameter cortical TPR. Even the bone is thin enough. Okay. Well, if the bone is quite thick, like width of the bone is quite good enough, there you can do the bypass even with the 4.2 diameter. Okay, but here we did with a 3.5 diameter implants, especially lower right side. And this is a follow-up of the patient after 2 years. This is the patient before and after. Okay. That's his transformation from day 1 to day 5. Okay, tremendous change in his confidence. Another case, see, 19-year-old girl, all teeth are compromised and she is not able to deliver well. Her social life is impaired. So many things are there. Okay. Plus the bone is very compromised. Now she don't care about the bone. What she need at this age is a beautiful smile and beautiful and the function by which she can at least chew. She don't care what kind of surgery is going to be done. Okay. So though it was a very complex case, we decided to give definitely for this girl a screw return option so that anything requires in futures can be changed. Okay. So we placed the implants in the anterior canine buttress region, and zygomatic implants were placed, and pterygoid implants also were placed into the buttress. Okay. Now, because of the angulation of the OPG, it will be seen different in different angulation. But the day 5 is the very accurate OPG. So it's not in one near the position have changed. It's just that the OPG patient must have changed head position. Okay, that's an accurate position for the day 5. And if you see this before and after, because the bone is very thin, we have to place implant from buccal side in the lower anterior, lower posterior. So that's why we have a buccal hook in patient's mouth. Okay. But patient received fixed teeth and she was able to chew well. She's absolutely enjoying. Because she's enjoying, she's in a good situation to smile. Okay, so that kind of impact is being done in her life. Okay, because
What is love exactly?
she is
Next one needs before you.
because she got what she wanted. This is the
This
smile of
today.
happiness. The tears comes first, particularly. It was a tear. Okay, so this transformation was very close to my heart. But such transformation definitely needs to go through certain phases. It's not like, you place the implants and you got the teeth. Different labs will give different results, and same lab can give you different results with the different clinicians. So it's not nothing related to the lab. It is related to what information you're providing to your labs. Okay, that's the most important thing. Because I keep seeing my lab give sometimes very good result to someone and sometimes very bad result to someone. So it's not my lab fault, it's the fault of my fault of the particular clinician who is not able to correct the lab right moment and not able to give a correct information to the lab. Okay, it's both are very important. If lab is doing mistake, correct them. If suppose and give correct information so that lab don't do unknown mistakes, right? So this is two important things. Okay, so I'll just show you in short prosthetic face how we do it. So this is the particularly patient periodontally compromised dentition. Okay, this implant has been placed. If we are doing something manually, we need to do something called open tray transfer impression. Nowadays, people, a lot of doctors use the scan bodies and just they scan it. So that is one easy method. But people who don't have access to this digital protocols, you still can go ahead with the manual open tray impressions where you attach the open tray, transfer to the multi-unit and join it them with the help of patent resin. There are different methods. One is with the help of your floss. Another is help with the burr or any metal bar, and then you cut the areas where to avoid the shrinkage, and then you take the impression, rejoin it, and then take the impression. So it's a whole new topic itself. I'm sure some webinar will be conducted on such kind of impression making. Okay, and once that is there ready after the zig trial, you verify, you tell patient technician to go ahead, he will make the bar. Okay, this is a metal cobalt chromium bar. Over this bar, your teeth set will set. Okay, and you will check patient smile and everything, the occlusion, everything is done. Okay, and these two information is now scanned by the technician. Okay, and he will make the superstructure which will be fitting on the bar, and this superstructure is milled out of something called reinforced acrylic. So this is nothing but the milled hybrid. Okay, this superstructure will fit on this metal bar in the patient's mouth, and this is the final result you will be giving. Now, these technicians will fuse this and they will do this artwork of making a processes like lifelike appearance. And this processes definitely can be used as a long-term screw retain provisional processes. Really long-term, more than 5 years, it can be used. Yeah. Okay. So this is how we used to do it with the manual protocols. This is the case with the same case with the 4 years follow-up. Okay, so that's analog method, but there's also a digital way. Okay, so I will show you one guided surgery. How much time is left? Yeah, okay. So this is a digital way. Now, if you see a patient comes to me today like this, and so if I need to place the implants, I'll have to trim this bone completely. Okay, and I will place the implant at the level of this particular line in the maxilla. Okay, so in order to do that, I'll have to trim the bone. Okay, so this case is specifically done with a guided approach. We also, but here we use not complete guided, not fully guided, but we use a pilot guided. Okay, and we use stakeable guide. So what is that? I will be giving you. And we gave an immediate temporization, immediate loading to the patient. Let's see how exactly we did this case. So before of the patient, once first visit, when the patient came, we scanned him intraoral before and after. Everything was scanned. Okay, so scan is ready. The exocad is ready with us. Okay, on the basis of this exocad, the technician will do the teeth setting. That is called digital mock-up. Now, okay, he will do this mock-up on the computer, on exocad software or any other software, whichever the technician is comfortable. A digital mock-up is ready. This is the digital mock-up. So this is converted to this. Okay, this is called digital mock-up. At the same time, this all the CBCT data and the scanning data is being sent to the people, to the lab, which will make the fabrication of the guides. Now he will make something called guide, which is called bone reduction guide, which will fit and it will reduce the bone. Okay, and over that there will be another guide which will be sitting, which will give the placement, direction of the placement of the implants. Okay, so or drilling. Now this is called bone reduction guide. Okay, and over that another guide, this is also called as primary guide. On over that another guide which is called secondary guide will be stake. Okay, this will be staked inside it. That means it is called stakeable guide. Okay, now if you see the secondary guide has the holes through which your drills will go. Now here, because we are doing only pilot guided procedure, only one drill will go. If it is a fully guided procedure, this drill will, this particular sleeves will not have just 1 millimeter, 2 millimeter of hole. It will have a 5 millimeter of hole, and complete set of drills will go, and even the implant will be placed through that guides. That is called fully guided procedures. That for that advanced software is needed. Here, if you see, all the guides are like a denture. Okay, whereas the particularly those kind of guides, they need the tubular guides. No, specifically they are not a denture kind of a thing. So where denture, when you reflect the flap, the fit will get compromised, and there you may get error also. So that's why when you're doing fully guided procedure, you will get the something called tubular guide, and tubular guides is not very easy to make. That's why the QuickDent is coming with some QuickDent 3D solutions, where they will be having particularly a software where it is easy to make the tubular guides also, and also the guided kits will be there. That will be shortly available. So we'll be having a one fully, I think, shortly, one complete session on a guided procedures sooner or later, probably in June, July. Okay, so this is one thing. But so this is called a stakeable guide for a pilot guided procedure. Okay, now here what will happen? The digital mock-up which is being done by the previous technician, that file will go to this particular person who is making guides, and he will fabricate the teeth which will sit into this digital this particular base guides. That is the primary guide. Okay, see, okay, so he is making the teeth like this. So my teeth is ready before the procedure, so my teeth can fix on the base guide or primary guide like this. Clear, everybody? So immediately after my surgery, my teeth is ready. So what is happening? First step, we are opening the flap, attaching the primary guides. Over that, we'll attach the secondary guide, and through the secondary guides, we are drilling, which you can see here. Okay, I'll repeat again. See the primary guide, secondary guide, and from secondary guide, I'm drilling. That is pilot guided. Okay. After this, primary guide is removed, and we place the implants. Okay. Here, same way. Primary guide, secondary guide, and then placement. Now, this guide is a kind of an acrylic or a plastic, bioplastic. Okay. This can also be available in cobalt chromium material. So this is more stable. Okay. So more accurate, I would say. It will not wobble. Okay. So this is the pilot guide. Now, after this, what will happen? We will remove all the guides and we'll place the implants. Okay. And after placing the implants, we'll be attaching the multi-unit over it. If you see here, we have attached the multi-unit. We took the scan also of the patient. Okay. And what we did, we used something called your rubber base, and we recorded the position of the multi-unit on this particular prosthesis. Okay. Now there are two options. Either you will drill it and catch it like a temporary dentures, what you do, immediate temporization, or else you will send it to the lab and you will make a new impression and send it to the lab and ask technician to catch it in the over the cast. So it's easy for me to do that. So I didn't catch it in patient's mouth because of the surgery. Patient was very tired. So we just took the impression, digital impression with the scan bodies, send it to the lab. They printed the cast, and on that cast, so this impression is being taken. The cast is printed, and on this cast, now he will catch the tie cylinders, titanium cylinders. Okay. Now the my temporary process is ready, right? Now on like third visit or day 2 of the surgery, I will be placing the prosthesis, transitional prosthesis to the patient. The only disadvantage of this particular method is there is no metal bar inside. So if you need to have a metal bar, you'll have to make another visit, that is day 3 of the surgery, and then you can catch the temporary process on the metal bar. That is also an option, right? So, but here in that case, your tie bases instead of your titanium cylinder, you will have to use your tie bases. Okay, so that's an optional thing. So how do we now change this transitional process to the permanent processes? We will call the patient. We will just scan all this after 2 months of healing everything. We will scan this transitional process completely, upper, lower, wherever it is broken, whatever it is. We remove the prosthesis. We will scan now the new position of the implant with respect to new soft tissue position. Okay, we done that. Current soft tissue profile, everything has been scanned. These two data will be sent to the technician. The technician will merge this impression and the teeth together. Okay, with this particular method, which is called, which is on Exocad, with the help of soft tissue as a fixed landmark, they can do that. Now, what happened after on this? He will prepare a metal bar and a teeth with a shell. Okay, this is a trial. So on this metal bar, we will put this shell trial, the same acrylic shell trial, which I showed you in previous case. So this is a hybrid prosthesis, milled hybrid process. We will check that everything is okay. Once it is okay, we will give a green signal to technician, and technician will fabricate the final processes. This final process is then fixed to the patient, and this is the final of the patient. I hope you got the clear idea now. So you have a before, then day 2, that is the immediately on the day 2 of the surgery, transitional processes, and then after 2 months, you just use all the data of the transitional processes if it is accurate, and use that data to fabricate the new processes. Okay, so these are the certain cases which is done by my students. So they are also doing zygoma, they are also doing pterygoids during our workshop. So shortly we will be having a guided workshop, because where we will be showing how to approach with the guided digital protocols. That's a new thing today in market. The dates will be announced shortly. You can be in touch with me on Instagram, and you can access to multiple cases which I keep posting on my Instagram channel, Dr. Mayur Khairnar. And I always say what's matter most is to improve the quality of life, no matter what. I already showed you on the techniques of immediate loading, but I have also shown you 2-3 cases where I did the delayed loading. So it's all matters whether my immediate loading is going to improve the quality of life of the patient or not. If it is not, then please do delayed loading or whatever it is. If my particular treatment is going to compromise particular quality of life of the patient, I will not do that. Okay. we will prefer to go. For example, I have seen cases where 6, 7, 8 is missing, and 8 zygoma is being placed, and 6 sorry, I'm very sorry. 6, 7, 8 is missing in the maxilla. 8 pterygoid implant is placed, and 6 region, instead of doing a sinus lift where 3-4 millimeter bone is there, doctors are placing zygomatic implant. So that's not a good way. Okay, so zygoma is a pillar of the face, and if it is used, should be used as a backup when nothing works. So it's good idea to do delayed loading and do sinus lifts and wait for a certain period of time. So it's what matters is to improve the quality of life of the patients. Okay, so with this, I would like to say thanks to Dentist Channel Online and QuickDent for giving me an opportunity to give you insight about how to do full mouth reconstruction in periodontally compromised dentition. Thank you so much. With this, I would like to hand over to Shreya. Thank you so much, Shreya, for hosting. Thank you so much again.
Thank you so much, Dr. Mayur. Now it's Q&A time. So if you have any questions, you can put your questions in Q&A box. We will be waiting for your questions for about like 3 to 4 minutes. Actually, you have already explained everything about this webinar and in detail, actually. So I truly appreciate your, your work that you have done, and you have made satisfied, like patient satisfaction is very important, right? So I think all of the patients, they are very satisfied. So obviously, doctor, you're doing a great job, great work.
Thank you so much.
And with this webinar session, you showcased your all the cases, what we can do in in future if we come across through like in such cases. So I think it will be a very good thing for all the attendees who have attended this webinar. And yes, thank you once again for for your expertise, for your clarity, and for it was a kind of you can say engaging delivery of this webinar session of all the cases. So yes,
Thank
and
you so much. Thank you.
let me see if there are any questions. There are no questions yet. So I think this is the end of this session. So thank you once again for such a insightful and such an informative webinar session. Thank you, doctor. And
Thank
thank
you
you
so
everyone
much.
for joining with us.
Thank you so much. Thank you so much.
Goodbye.